Rheumatology and dermatology are closely linked due to several autoimmune and inflammatory conditions that affect both the joints and the skin. Many rheumatic diseases have dermatological manifestations, and in some cases, skin symptoms can precede or accompany joint involvement. Here are some common examples of this connection. 1. Psoriatic arthritis, PSA. Psoriatic arthritis is a type of inflammatory arthritis associated with psoriasis, a chronic skin condition. Patients with PSA typically have skin plaques that precede joint symptoms. Psoriasis affects the skin, while psoriatic arthritis primarily affects the joints, tendons, and entheses, attachment points of tendons and ligaments to bone. 2. Systemic lupus erythematosus, SLE. This autoimmune disease affects multiple organs, including the skin and joints. Skin rashes, such as the characteristic butterfly-shaped rash on the face, are common in lupus, along with joint pain and swelling. 3. Dermatomyositis. This is an inflammatory myopathy characterized by muscle weakness and distinctive skin rashes, including the heliotrope rash on the eyelids and Gottron's papules on the knuckles. Both muscle and skin inflammation are prominent features of the disease. 4. Scleroderma, systemic sclerosis. Scleroderma involves hardening and thickening of the skin, but it also affects the joints, blood vessels, and internal organs. Rheumatologists and dermatologists collaborate to manage the skin fibrosis and joint stiffness in these patients. 5. Rheumatoid arthritis, RA. Although RA primarily affects the joints, it can have skin manifestations like rheumatoid nodules, vasculitic ulcers, and palmar erythema. In some cases, severe RA may lead to skin necrosis due to vasculitis. 6. Vasculitis. Several types of vasculitis, such as cutaneous leukocytoclastic vasculitis, can present with skin lesions, including palpable purpura. Some systemic forms of vasculitis, like polyarteritis nodosa or granulomatosis with polyangiitis, GPA, can also involve skin and joints. 7. Behçet's disease. This is an inflammatory condition that affects multiple systems, including the skin and joints. Oral and genital ulcers are common, as are skin lesions such as erythema nodosum. Arthritis is a common joint manifestation. Rheumatologists and dermatologists often collaborate in diagnosing and managing these diseases, as skin findings can provide important clues to the underlying rheumatic condition. Rheumatic diseases often present with overlapping dermatologic and rheumatologic manifestations, which makes it crucial to recognize the interplay between the skin and the musculoskeletal system. Here's an in-depth look at the rheumatic and dermatologic aspects of specific rheumatic diseases. 1. Psoriatic arthritis. A. Dermatologic aspects. Psoriasis, characterized by thickened, red skin with silvery scales, often seen on the elbows, knees, scalp, and lower back. Nail changes, such as pitting, onycholysis, nail separation, and yellow discoloration, are common. Koebner phenomenon. New psoriatic lesions develop at sites of skin trauma. Rheumatic aspects. Enthesitis. Inflammation of the entheses, points where tendons or ligaments attach to bone, commonly seen in the Achilles tendon and plantar fascia. Arthritis. Typically affects the distal joints of the fingers and toes, leading to dactylitis, sausage digits. Symmetrical or asymmetrical arthritis can occur, resembling rheumatoid arthritis or spondyloarthritis, respectively. 2. Systemic lupus erythematosus, dermatologic aspects. Malar, butterfly rash, a red, flat, or raised rash across the cheeks and nose, sparing the nasolabial folds. Discoid lupus, chronic, scarring lesions, primarily affecting the face, scalp, and ears. Photosensitivity. Sun exposure can provoke a lupus rash or exacerbate systemic symptoms. Rheumatic aspects. Arthralgia arthritis. Non-erosive, symmetric joint pain, primarily affecting small joints such as the hands, wrists, and knees. Myositis. Muscle inflammation leading to weakness, which may accompany skin involvement. 3. Dermatomyositis. Dermatologic aspects. Heliotrope rash, a violet or dusky rash over the eyelids, often with swelling. Gottron's papules. Red or violaceous raised lesions over the knuckles, elbows, and knees. Schall sign. Redness over the upper back and shoulders. Mechanic's hands. Rough, cracked skin on the sides of the fingers resembling a mechanic's hands. Rheumatic aspects. Muscle weakness. Proximal muscle weakness, shoulders and hips, is a hallmark of dermatomyositis. Arthritis, inflammation of the joints, is less common but can occur in conjunction with muscle involvement. 4. Scleroderma, systemic sclerosis. Dermatologic aspects, skin thickening. The hallmark of scleroderma is skin fibrosis, causing tight, shiny, and thickened skin, particularly on the hands, face, and extremities. Raynaud's phenomenon, episodic vasospasm of the small blood vessels in the fingers and toes, triggered by cold or stress, causing pallor, cyanosis, and redness. Telangiectasias, small dilated blood vessels visible on the skin, often on the face and hands. Rheumatic aspects, joint contractures. As the skin thickens and tightens, it can restrict joint movement, leading to flexion contractures, especially in the hands. Arthralgia and arthritis, stiffness, swelling, and pain in the joints, though erosive arthritis is rare in scleroderma. Number 5, rheumatoid arthritis, dermatologic aspects. Rheumatoid nodules, firm, subcutaneous nodules often found on pressure points such as the elbows, forearms, and Achilles tendon. Vasculitic lesions. In severe RA, vasculitis can cause skin ulcers, especially on the lower extremities, and small necrotic lesions at the fingertips, periungual infarcts. Rheumatic aspects. Symmetrical polyarthritis. The most characteristic feature of RA is inflammation of the joints, particularly in the hands, wrists, and knees. This often leads to deformities such as ulnar deviation, swan neck deformity, and boutonniere deformity. Morning stiffness, joint stiffness lasting for more than an hour, particularly in the morning. 6. Vasculitis. Dermatologic aspects, palpable purpura, red or purple raised spots on the skin, usually due to inflammation of small blood vessels, common in small vessel vasculitis such as cutaneous leukocytoclastic vasculitis. Livedo-reticularis, a net-like, purplish discoloration of the skin commonly associated with systemic vasculitis such as polyarteritis nodosa. Ulcers and gangrene. Severe vasculitis can lead to skin ulcerations, particularly in the lower extremities, and in extreme cases, gangrene. Rheumatic aspects, arthralgia and arthritis. Joint pain and inflammation are common in systemic vasculitis, though less destructive than in RA. Organ involvement. Depending on the type of vasculitis, multiple organ systems can be affected, including the kidneys, lungs, and nervous system. 7. Behçet's disease. Dermatologic aspects. Oral and genital ulcers. Recurrent, painful ulcers are a hallmark of Behçet's disease. Oral ulcers are often the first sign, and genital ulcers, though less frequent, are deeper and can scar. Erythema nodosum. Tender, red nodules, typically on the shins, can also occur. Rheumatic aspects. Arthritis. Non-erosive arthritis, commonly affecting the knees, ankles, and wrists. Venous thrombosis. Behçet's can involve large veins, leading to thrombosis and complications such as deep vein thrombosis or pulmonary embolism. 8. Sarcoidosis. Dermatologic aspects. Erythema nodosum. Red, tender lumps on the shins, often an early sign of sarcoidosis. Lupus pernio. Chronic violaceous lesions that typically affect the nose, cheeks, and ears. Rheumatic aspects. Arthritis. Sarcoidosis can cause acute arthritis, often affecting the ankles, with associated erythema nodosum. Lefgren syndrome, a specific manifestation of sarcoidosis characterized by the triad of erythema nodosum, arthritis, and bilateral hilar lymphadenopathy. Conclusion. Rheumatic diseases often have significant skin involvement, which can provide important clues for diagnosis and monitoring disease activity. The collaboration between rheumatologists and dermatologists is critical for comprehensive patient care, particularly when treating conditions with multi-system involvement. Skin manifestations may be the first or most prominent sign of underlying systemic disease, and proper identification and management can improve overall outcomes. Mucocutaneous complications are common in rheumatic diseases, often affecting both the skin and mucous membranes, such as the mouth, nose, and genitals. These manifestations can range from mild to severe and can provide diagnostic clues or indicate disease activity. Here's an overview of the mucocutaneous complications seen in various rheumatic diseases. 1. Systemic lupus erythematosus, SLE, mucocutaneous ulcers, oral ulcers. Painless ulcers on the palate, gums, or inside the cheeks are a common finding in SLE. Nasal ulcers. These can cause discomfort and crusting, often overlooked in clinical evaluations. Skin rashes. Malar, butterfly rash. Red or pink, often brought on by sunlight, appearing on the cheeks and nose but sparing the nasolabial folds. Discoid lupus. Scarring, hyperpigmented or hypopigmented plaques, commonly seen on sun-exposed areas. Photosensitivity, skin reactions to sunlight, often manifesting as rashes or systemic flare-ups. Number two, Behçet's disease, oral and genital ulcers, recurrent aphthous stomatitis. Painful, recurrent oral ulcers are a hallmark of Behçet's disease. These ulcers may affect the lips, tongue, gums, and buccal mucosa. Genital ulcers, deep, painful ulcers can affect both men, scrotum, penis, and women, vulva, vagina, often leading to scarring. Skin lesions, erythema nodosum, tender, red nodules, particularly on the shins. Pustular lesions. Behçet's may cause acne-like pustules, especially in areas of trauma, pathergy phenomenon. 3. Sjogren's syndrome, mucosal dryness, xerostomia, dry mouth. Decreased salivary production leads to dry mouth, difficulty swallowing, and an increased risk of dental caries and oral infections, e.g. candidiasis. Dry eyes, keratoconjunctivitis sicca, eye dryness and irritation due to reduced tear production. Oral ulcers. Some patients with Sjogren's syndrome may experience recurrent oral ulcers, though less common than in Behçet's or SLE. 4. Dermatomyositis, mucosal involvement. Oral ulcers. Ulceration and inflammation of the oral mucosa may occur in some cases, contributing to difficulty in eating and swallowing. Skin rashes. Heliotrope rash, a characteristic violet or dusky discoloration around the eyes, often with swelling. Gottron's papules, raised reddish-purple plaques on the knuckles, elbows, and knees. 5. Rheumatoid arthritis, mucocutaneous nodules. Rheumatoid nodules. These firm, subcutaneous nodules are found in about 20% of RA patients, often on pressure points such as the elbows and forearms. Vasculitis-related skin and mucosal lesions. Oral and nasal ulcers. Severe, untreated RA can lead to vasculitis, which may cause ulcers in the mouth and nasal mucosa. Cutaneous vasculitis, small vessel vasculitis, may manifest with purpura, petechia, or skin ulcerations, particularly on the legs. 6. Systemic sclerosis, scleroderma, mucocutaneous involvement, oral telangiectasia, small dilated blood vessels visible on the lips, face, and inside the mouth. These can cause minor bleeding. Microstomia, tightening of the skin around the mouth can lead to a reduction in mouth size, making it difficult to open wide, microstomia. This may cause oral hygiene challenges and difficulty with dental care. Oral dryness. Due to salivary gland involvement, patients may experience xerostomia. Skin tightening and ulceration. Sclerodactyly, tight, shiny skin on the fingers and hands, which may ulcerate due to ischemia, digital ulcers. Calcinosis. Calcium deposits can form under the skin, leading to painful ulcers or white nodules, particularly on the fingertips. 7. Vasculitis, oral and nasal ulcers. Conditions like granulomatosis with polyangiitis, GPA, formerly Wegener's granulomatosis, often feature oral and nasal ulcers due to granulomatous inflammation. Nasal involvement may lead to crusting, perforation of the septum, and saddle nose deformity. Cutaneous vasculitis. Palpable purpura, petechiae, and ulcerations can be seen on the skin, particularly in conditions like Henoch-Schönlein purpura, HSP, and cryoglobulonemic vasculitis. Mucosal involvement. In severe cases, vasculitis can involve the mucosa, leading to painful ulcers in the oral cavity or genital regions. 8. Psoriatic arthritis, PSA. Mucosal involvement. While less common than skin involvement, some patients with PSA may develop mucocutaneous symptoms such as oral ulcers. Skin manifestations, psoriatic plaques. Thick, red skin with silvery scales, usually found on the scalp, elbows, knees, and lower back. Nail pitting and onycholysis, nail separation, are common. Koebner phenomenon. New psoriatic plaques may form at sites of skin trauma. 9. Reactive arthritis, Reiter's syndrome, mucocutaneous involvement, oral ulcers. Painless oral ulcers, which may go unnoticed by the patient, are common. Keratoderma blenneragicum, hyperkeratotic, scaly skin lesions, often on the palms and soles, are characteristic of reactive arthritis. Circinate balanitis, painless, circular, red erosions on the glans penis, a common genital manifestation. Conclusion. Mucocutaneous complications of rheumatic diseases are varied and may involve both the skin and mucous membranes. Recognizing these manifestations is important for early diagnosis and for tracking disease activity, as they can reflect systemic inflammation or autoimmune processes. Rheumatologists and dermatologists often collaborate to manage these conditions, given their overlap and the impact on patients' quality of life. Proper management of mucocutaneous symptoms is key to improving patient outcomes. Many skin diseases are associated with systemic rheumatic complications, as some dermatologic conditions also involve musculoskeletal, vascular, and other organ systems. These manifestations may present alongside or after the skin disease develops, and their identification is crucial for proper diagnosis and management. Below are some examples of skin diseases with rheumatic complications. Step 1. Psoriasis and psoriatic arthritis, SA. Psoriatic arthritis. About 20 to 30% of patients with psoriasis develop PSA, an inflammatory arthritis. It can manifest as oligoarthritis, involvement of a few joints, usually asymmetrically. Polyarthritis, similar to rheumatoid arthritis, affecting multiple joints symmetrically. Axial involvement, spondylitis or sacroiliitis may occur, causing back pain and stiffness. Dactylitis, inflammation of entire fingers or toes, leading to sausage digits. Enthesitis, inflammation at the sites where tendons or ligaments insert into bone, e.g., Achilles tendon. Other rheumatic manifestations. Psoriasis is also linked to an increased risk of osteoporosis, particularly in patients with SA. Tendinitis and tenosynovitis are common in SA patients, especially in the Achilles tendon and plantar fascia. 2. Systemic sclerosis scleroderma. Rheumatic complications, sclerodactyly, thickening and tightening of the skin on the fingers, leading to reduced joint mobility and contractures. Arthralgia and arthritis, joint pain and stiffness, which can be a significant symptom in systemic sclerosis. Tendon friction rubs, a rubbing or creaking sensation over the tendons due to inflammation and fibrosis, particularly in the hands and feet. Raynaud's phenomenon, vasospasm of the small vessels in the fingers and toes, causing color changes, white, blue, red, and pain. This is a hallmark of systemic sclerosis, but can also occur in other connective tissue diseases. Calcinosis. Calcium deposits form in the skin, often over joints, leading to painful nodules that can ulcerate. 3. Lichen planus. Rheumatic complications. While primarily a skin condition characterized by purplish, itchy, flat-topped papules, some forms of lichen planus are associated with arthralgia, joint pain in conjunction with skin lesions. Lichen planopilaris, a form of scarring alopecia that can affect hair follicles, leading to permanent hair loss, and is occasionally associated with autoimmune joint symptoms. Association with autoimmune diseases. Lichen planus may be associated with conditions like systemic lupus erythematosus, SLE, primary biliary cirrhosis, where both cutaneous and systemic rheumatic features, e.g., arthritis, arthralgia, are seen. 4. Dermatomyositis, rheumatic complications. Proximal muscle weakness. The primary rheumatic feature of dermatomyositis is muscle inflammation, leading to weakness in the shoulders, hips, and neck. Gottron's papules, raised erythematous lesions on the knuckles, elbows, and knees, often seen with joint pain. Arthritis. Dermatomyositis may present with joint inflammation, though this is usually non-erosive. Interstitial lung disease, ILD, systemic complications may include pulmonary involvement, which is more common in the antisynthetase syndrome variant of dermatomyositis. Overlap with other connective tissue diseases. Dermatomyositis can overlap with other rheumatic diseases like SLE or systemic sclerosis, leading to mixed presentations of skin and systemic features. Number 5. Cutaneous vasculitis. Rheumatic complications. Arthritis and arthralgia. Many forms of vasculitis, such as Carr-Hennock-Schönlein purpura, HSP, or cryoglobulinemic vasculitis, involve joint pain and swelling. Palpable purpura. The most common skin manifestation of small vessel vasculitis, often accompanied by joint pain, especially in the lower extremities. Polyarteritis nodosa, a form of systemic vasculitis that may present with nodular skin lesions, livedoreticularis, and systemic symptoms such as joint pain, muscle pain, and peripheral neuropathy. Number 6. Erythema nodosum, rheumatic associations. Erythema nodosum is an inflammatory condition characterized by painful, red nodules, usually on the shins. It is often a reaction to systemic diseases like sarcoidosis, inflammatory bowel disease, IBD, or streptococcal infections. Sarcoidosis. Erythema nodosum is commonly associated with sarcoidosis, and joint pain, arthralgia, or arthritis can occur in this context, often seen as part of Lefgren's syndrome, erythema nodosum, bilateral hilar lymphadenopathy, and arthritis. Number 7. Erythema multiforme. Rheumatic associations. Erythema multiforme is a hypersensitivity reaction that can involve the skin and mucous membranes. Although it primarily affects the skin, some cases have been linked to systemic autoimmune diseases like SLE, where joint pain and inflammation may also occur. This condition may be triggered by infections, e.g., herpes simplex virus, or medications, and it may overlap with rheumatic conditions such as reactive arthritis or vasculitis. 8. Pyoderma gangrenosum. Rheumatic complications. Pyoderma gangrenosum is a rare, ulcerative skin condition that often occurs in association with systemic diseases like rheumatoid arthritis, RA, inflammatory bowel disease, IBD, and ankylosing spondylitis. Arthralgia and arthritis. Patients with pyoderma gangrenosum may experience joint pain and arthritis, particularly when associated with RA or IBD. Pustules. The initial lesions may resemble small pustules, which rapidly progress to painful ulcers. 9. Lupus pernio, sarcoidosis, rheumatic complications. Lupus pernio is a chronic form of cutaneous sarcoidosis, presenting as violaceous plaques or nodules on the nose, cheeks, and ears. Arthritis and arthralgia. Joint pain or arthritis is common in sarcoidosis, especially in patients with skin involvement. Sarcoidosis can also cause muscle pain and granulomatous inflammation in the joints and muscles. Lefgren syndrome. This acute form of sarcoidosis is characterized by erythema nodosum, arthritis, and bilateral hilar lymphadenopathy. 10. Necrobiosis lipoidica, rheumatic associations. Many skin diseases are associated with systemic rheumatic complications, as collaboration between rheumatologists and dermatologists is essential because many diseases have both skin and systemic manifestations, which can involve the musculoskeletal system, internal organs, or immune system. The need for referral from one specialist to the other arises when the clinical features of a patient's disease cross the boundaries of either specialty. When a rheumatologist should refer to a dermatologist. 1. Uncertain or complex skin manifestations. If a rheumatologist encounters unusual or unclear skin rashes, plaques, or lesions that do not align with the typical presentations of common rheumatic diseases, e.g., rheumatoid nodules, psoriatic plaques, a dermatologist's expertise is valuable for diagnosis. Skin biopsy may be necessary to confirm conditions such as cutaneous vasculitis, dermatomyositis, or other autoimmune skin diseases. 2. Worsening psoriasis and psoriatic arthritis, PSA. In patients with psoriatic arthritis, PSA, if the skin psoriasis worsens despite rheumatologic treatment, referral to a dermatologist is recommended for specialized management of skin symptoms, e.g., topical therapies, biologics targeting skin disease. 3. Persistent or severe cutaneous lupus. When patients with systemic lupus erythematosus, SLE, have severe or persistent cutaneous lupus erythematosus, discoid lupus, malar rash, that is resistant to immunosuppressive therapy, dermatologists may offer additional treatments, such as antimalarials or topical steroids, tailored to skin disease. Number 4. Dermatologic side effects of medications. Some rheumatologic treatments, e.g. methotrexate TNF inhibitors, may lead to drug-induced skin reactions, such as rashes, photosensitivity, or psoriasis-like lesions. Dermatologists can help manage these adverse effects with appropriate dermatologic interventions. 5. Suspected skin cancer in systemic sclerosis or dermatomyositis. Patients with systemic sclerosis or dermatomyositis have an increased risk of non-melanoma skin cancers and cutaneous malignancies. Dermatologists play a key role in early diagnosis through skin examinations and biopsies, as well as in monitoring high-risk patients. 6. Unexplained skin ulcers. If a rheumatologist encounters patients with chronic or unexplained skin ulcers, e.g., in systemic sclerosis, vasculitis, or pyoderma gangrenosum, referral to a dermatologist is warranted for more specialized diagnostic and treatment approaches. 7. Severe or refractory Raynaud's phenomenon with skin involvement. In cases of Raynaud's phenomenon with significant skin changes, ulcers, gangrene, collaboration with dermatology is important to prevent further tissue damage and for wound care management. when a dermatologist should refer to a rheumatologist. 1. Skin disease with joint or musculoskeletal symptoms. If a patient with psoriasis develops joint pain, swelling, or stiffness, referral to a rheumatologist is necessary to evaluate for psoriatic arthritis, PSA. Similarly, in conditions like hidradenitis suppurativa, where patients may develop joint inflammation or other systemic features, referral is needed. 2. Suspected systemic autoimmune disease. Dermatologists often encounter cutaneous manifestations of systemic diseases such as lupus, dermatomyositis, systemic sclerosis, or vasculitis. If these are accompanied by systemic symptoms, fatigue, joint pain, muscle weakness, etc., a rheumatologist's assessment is essential. Examples include butterfly rash or discoid lesions with joint pain and fatigue suggesting SLE, Gottron's papules or heliotrope rash with muscle weakness indicating dermatomyositis. 3. Recurrent oral or genital ulcers. Patients with recurrent oral or genital ulcers, e.g., Behçet's disease, should be referred to a rheumatologist, as these ulcers may be part of a systemic vasculitis or other autoimmune conditions that require systemic immunosuppressive treatment. 4. Widespread or necrotic cutaneous vasculitis. Cutaneous vasculitis, especially if widespread or causing necrosis, may indicate systemic vasculitis involving other organs, kidneys, lungs, etc. A rheumatologist should be involved to assess for systemic disease and initiate appropriate immunosuppressive therapy. 5. Scleroderma-like skin changes. If a dermatologist sees a patient with sclerodactyly, skin tightening, or Raynaud's phenomenon, referral to a rheumatologist is necessary to evaluate for systemic sclerosis, scleroderma, especially if there are other signs of systemic involvement, esophageal dysmotility, pulmonary fibrosis. 6. Suspected rheumatic drug reactions. If a patient receiving a rheumatologic drug, e.g., methotrexate, anti-TNF agents, develops a drug-induced skin reaction, the dermatologist may need to refer back to the rheumatologist for modification of the medication or alternative therapy. 7. Livedo reticularis with other systemic symptoms. Livedo reticularis, a vascular pattern on the skin, may indicate underlying systemic autoimmune diseases like antiphospholipid syndrome, APS, or systemic vasculitis. If patients also have other symptoms like blood clotting issues, joint pain, or neurologic problems, referral to a rheumatologist is indicated. 8. Severe or chronic erythema nodosum. Dermatologists encountering erythema nodosum, that is recurrent or resistant to treatment, especially in the context of other systemic symptoms, e.g., joint pain, fatigue, should refer to a rheumatologist to evaluate for an underlying systemic disease like sarcoidosis, IBD, or lupus. Conclusion. Referrals between rheumatologists and dermatologists are crucial when patients present with overlapping skin and musculoskeletal or systemic manifestations. Both specialties need to collaborate closely to ensure comprehensive care, as some conditions can significantly affect both the skin and internal systems, requiring a multidisciplinary approach for optimal management. Early referral ensures proper diagnosis, treatment, and monitoring of disease progression.